Mustafa to it. Sorry, yeah. It looks right? Okay.
Yeah. Oh, yeah.
No, I will keep that. Okay.
I'd like to call this House to order and to open the government's case and to invite the Prime Minister.
Chill. In a context that we are facing a rare medical services that exist within your country, and at the same time, if you do not exist as a doctor, there's going to be one patient just because he's wounded and there are no one to inject proper antibiotics to him to die, and your choice to advance your career or to choose to make profit come at the expense of the most vulnerable denominator of your society lose their life, we think is an abhorrent choice for you to make, and we think you should be restricted from that choice and we should not do that. I'm going to argue this debate for you on 3 levels. Firstly, I'm going to talk to you about what is justified for the state to restrict the capacity of doctors when it comes to making life choices in terms of like career advancements and making money. Secondly, I'm going to talk to you about the impacts of our program and our policy, that how it's effective in both short terms and long term. And lastly, I'll be talking to you about the necessity of why having local doctors is something and uniquely important and uniquely good. Let's look at the first argument in this debate. Why is justified to restrict the capacity of doctors? We need to understand the context of developing nations. We are talking about the context that the medical education as well as medical infrastructure, such as expensive labs and public hospitals, are largely provided by the government. Even if there are sectors that they do not, like for example, there are private sectors that they provide those sort of educations, they are highly dependent on the public infrastructure that the government has made. For example, most of IMU medical students, they end up in public hospitals to practice and get verified at the end of the day. So in one way or another, everyone is benefited by the huge investment that the government has made. The government has made that investment for a reason, because it understands the scarcity of these medical services that happens at the end of the day. But if you, as a doctor, choose to leave that particular country and say, God, fuck you to the government, that would come at a bad trade-off. What is the trade-off that's going to happen? We don't think it will come at a large harm to that particular individual, because we need to understand how this doctor live. If you are a doctor in any developing country, because of the scarcity of your profession and because of the social status that exists, you already are, you have fame, you have money, and you have a reasonable life to have. So your choice to give up that reasonable life that a lot of people don't have, the money that you already have, in order to advance yourself, comes at the expense of the government losing out a lot of money and resources that they have invested in you, but more importantly, comes at the expense of people losing their lives and not getting treated. That's why we think on the first level is justified. But the second level of this argument is that we need to understand and define the concept of being a doctor. The moment you make the choice to being a doctor, you choose to self-sacrifice a lot of stuff when it comes to your life. That's why you have, it requires commitment and do that. That's why when it comes to being a doctor, you make a choice to not to prioritize profit and to prioritize being a public servant to the people at the end of it. Before I go through my second argument, I take one PI. In the context of where there's no scarcity, but rather influx of doctors in case of scenarios like countries like India, would you still force these doctors to stay there? Mr. Speaker, in my second argument, I'm going to talk to you about in an instance. Firstly, we don't think that characterization is true in the most of instances, right? Just in one country like India, when you have like college drug Lakshmi and everyone become an engineer, that doesn't mean you have like proper doctors who are qualified to provide education for you. It's like fucking India, for God's sake, right? But secondly, we are talking about more important doctors. We're talking about like experts that they leave your country because they get better opportunities. And that nicely leads me to my second argument, right? See, we are talking about expert doctors, right? Yeah. The doctors that there is actually a good demand for them and there is actually a career advancement. The doctors that they actually have a job opportunity if they leave Bangladesh or India. We need these doctors because we don't have anyone like them inside the country. But more importantly, these are the doctors who provide education. These are the doctors who create syllabuses of your medical schools. These are the doctors who can form policies and join the government. These are the doctors who have received education from you in order to pay back, and now is the time that to pay back. And they can uniquely only pay back by themselves. This is important in short term and long term. In short term, now you are being benefited from this experts' existence within your country and the services they provide and the education that they provide. But in long term, you can be benefited from the policies that only these people can formulate because these are the only people who are qualified to do so. And at the end of the day, that's the conclusion to that argument. Well, let's look at the third argument in this debate. Why is critical for us to only use local doctors at the end of the day? We think the problem with Ebola outrage when it happened, it was not necessarily that, like, you know, the doctors and how it was operated. It was the presence of NGOs. The very reason, in the context of developing nations, is less likely for the local people to trust to the Western doctors and Western medicine, to trust to white doctors that exist. And we think that's quite justified. But even if it's not justified, it's hard to change at the beginning. Because given the background that exists within these people, the current xenophobia that is resulted by the colonial history, and is resulted by random Indian doctors going to Uganda and testing people for random tests that's going to happen at the end of the day. So the mistrust exists within these people and the doctor. So there is a barrier when it comes to the communication of these individuals and a white doctor or a doctor that is there because of aid or NGOs. We think under our paradigm, the only way that you can resolve that particular problem is to have the doctors that the patients can actually trust, and those doctors are only local doctors. But secondly, we think when it comes to diseases, they are mostly geographically specific diseases. For example, dengue exists in this part of the world, which does not necessarily exist in the other part of the world. So it's very important for you to have a local doctor who knows the symptoms and who knows the syndromes and can perfectly investigate the medicine, especially the experts that you have. But on the third level, we think when it comes to understanding your culture and not having communication barrier, it's very important to have as much commonality between doctor and patient that is possible. For example, in a lot of developing countries, it's not a norm that if you are a woman, you take your clothes off in front of a man who is a doctor, right? But this culture does not necessarily exist when it comes to developed nations at the end of the day. The moment that you have this cultural commonality, the moment that you don't have these communication barriers, and the moment that you have invested so much money to have an expert doctor, and now he's devoted and can pay back to the country, that's the only way you can change things. We are very proud to propose.
Thank you, Prime Minister. Now I'd like to call upon the Leader of Opposition to open the opposition.
All right. Mr. Speaker, when you become a doctor, You become a doctor because you have a desire to help people, as Bharat correctly pointed out, right? That sense of altruism is what separates good doctors from mediocre doctors. And what we are going to tell you is that a moratorium prevents altruism from forming in new doctors, and it undermines it in good doctors as well. We're going to attack the premise that, firstly, he said that, well, people become doctors because they have a sense of self-sacrifice. We thought that that made their model entirely unnecessary. But in the third world context, we thought that it was not justified to restrict the mobility of a doctor unless there was a particular crisis that they wanted to solve. Like, for example, the way Bharat talked about the spreading of Ebola in West Africa. But we think that there is a crisis that the very same moratorium that they wanted to impose has significant harms for several reasons that I will elaborate soon enough. Right? So my first two things that I will point out to you in this debate. Firstly, the reason why doctors emigrate in the first place and why it's a bad idea to stop them. And secondly, I will talk about the perception of the international community. But before that, some rebuttals that don't necessarily fit into my speech. Bharat talked about a third world country that had medical infrastructure, that the government has invested significant money in developing that medical infrastructure. But at the same time, they have that level of medical development. But his characterization that somebody would die because there wasn't a doctor present to administer a vaccine was extremely unlikely. Because we think that if they had invested that significant amount of medical development, that they would not have that kind of shortage of doctors that they would want to talk about, which means that it was still justified to allow doctors to travel overseas because there are places where there are better infrastructure, better facilities, where they could get better education and later subsequently return to serve their communities and whatnot. And also he talked about local doctors, like the necessity to create local doctors and the Ebola outbreak. But the problem was that West Africa did not have that level of development to train local doctors to handle a current crisis. That is why we told you that it was especially important that they don't restrict the ability of doctors to move, but instead facilitate and allow better mobility for first world doctors to emigrate to third world countries, and which I will demonstrate to you is not going to happen under their model. But what's more important here, right? And before I move on to the reasons why doctors immigrate, yes, Gemma.
Okay. 100,000 people die every year in Africa of diarrhea. Do you honestly believe there's no medical crisis?
There is a medical crisis. That is why his suggestion that local doctors will be able to mitigate it was extremely unlikely. But secondly, we tell you that that crisis is more likely to be mitigated when first world doctors move to these third world countries, which I will tell you, if a moratorium was imposed, will make them think twice about moving to those places in the first place, right? So why do doctors emigrate? We tell you that in order for local doctors to develop, that it is important to actually think about their education. We did not think that they were self-serving, profit-minded individuals who wanted to travel abroad and leave their fellows at home to die, right? We thought that they wanted to travel abroad or emigrate for personal reasons, but mostly for the expansion of knowledge, and because there was a lack of infrastructure in the areas that they were studying medicine in. We told you that we'll tell you that talent is unable to sufficiently develop in those third world countries, and that specialization of knowledge is exactly what is necessary to tackle the kind of outbreaks they want to talk about, to tackle the pandemics that they want to talk about. We don't need doctors in those cases who simply can treat the common cold. We thought that that was unnecessary to tackle the kind of problems that they were trying to propose. But we tell you that our counter proposition, which is simply enables incentives, right? We think that this very same organization that had enough money to impose moratoriums and it had enough money to build medical infrastructure, could also offer incentive to doctors to return to these countries after like their period education or for internships. We thought that incentives were superior than preventing them from leaving in the first place, and we tell you that it is superior to an international moratorium. So our counterprop is better because we think that local doctors will return, and if they don't, we'll offer incentives that make it more likely that they will. But we tell you that their model is going to create mediocre doctors who can do little more than treat things like the common cold and make them ill-equipped to subsequently handle the kind of outbreaks and pandemics that they were so worried about, right? On a second level, we told you that doctors who want to emigrate from first to third world countries would be less likely to emigrate if they thought that there was a precedent that they will be unable to leave. Because that's what a moratorium is, right? We think that the consideration that they may be locked down in that country and subsequently be prevented from moving away would mean that there was a high risk that there will be a subsequently lower aggregate of doctors moving into their countries, solving their kind of crisis that they want to talk about, right? Like mission doctors, they want to go there and work for an extended period of time, but they do also want a measure of control on which the period of they stay in that areas, because they want to be able to determine the duration of the mission and then move home. We think it's less likely that they would want to move in those areas if you could impose a moratorium and prevent them from emigrating away. Thirdly, when unexpected circumstances occur, we think that doctors do fear for their lives. Like For example, when 6 doctors were murdered in West Africa over the Ebola crisis, like the Nepal earthquake, we think that when political unrest suddenly occurs, or when there's an outbreak, that they are never particularly consented to certain dangers being imposed on them, and subsequently allowed to emigrate away if they felt that their life was particularly in danger, or they were ill-equipped or otherwise unable to handle the situation. We think that when things like political unrest suddenly occurs, there's no one monolith on doctors, right? We think that doctors, they are specially trained to handle these emergencies, and that doctors that aren't should be legitimately allowed to emigrate away from those countries, right? So we tell you that when you force them to stay, that their quality of work is definitely going to be affected, because number one, they are ill-equipped or unable to handle those circumstances. Secondly, they're resentful for the fact that you are making them stay despite them not being able to handle these circumstances. And thirdly, we tell you that it creates an illusion of doctors being present in an area which is not actually solving the problem. Barat.
Okay, see, you spent half your speech to tell us why it's unnecessary to force these people to stay in the country. And then you spend the rest of your speech to tell us why it's necessary to incentivize them to stay in the country. If there are benefits, why?
No, he's missing out the point. We think that doctors are likely to return when we offer incentives, so we are solving the very same problem they wanted. But we tell you that when you impose a moratorium, when you set a precedent that a doctor's mobility is restricted, that less doctors are going to want to move into third world countries because there's a possibility they will not be able to emigrate out. We thought that was particularly harmful and completely relevant in this debate, right? So thirdly, the perception of the international community, right? I already told you about how this may create an illusion of doctors being present, but not necessarily being functional because they were not trained or not equipped to handle a situation. We told you that these doctors will be more inefficient under these situations. But what's the problem? That the problem will also still persist under their model, because we told you that firstly, they'll be untrained and they'll be unable to deal with the circumstance. But secondly, we told you that also that first world doctors would think twice. In fact, they would think a lot, like many times over, before they decide to move into these third world countries, because there will be a precedent of them being unable to leave. So their model gives an illusion problems being solved. Just because you have a lot of doctors in the area does not mean that you have doctors that are equipped, they are able to handle the kind of situations that they want to talk about. And we tell you that more importantly, they also lose the political capital to create reforms on the medical community, because you just prevented these doctors from moving. We think that's a big infringement on their ability to, on their freedoms of mobility. We tell you that you subsequently lose political capital to actually create more reforms that may actually help the situation. So in comparison to our model, we think that incentives will allow greater mobility, and that makes doctors who want to emigrate for personal reasons better able to do so. Proud to oppose.
Well, Mr. Speaker, I barely know what to say about the counter proposal of the opposition. So I'm going to start my speech, and it's really regrettable that I have to do this, is to explain what a moratorium is and to explain what the word emigration means that is different from immigration. So, let's start there. Putting a moratorium on people leaving your country cannot legally be extended to people who are not citizens of your country, because as a government, you do not have the right to restrict their freedom of movement, because probably the outcome of that policy would be absolute international political scandal. The suggestion that a moratorium imposed by the Ugandan government on doctors of Uganda leaving to get jobs would extend to white workers of Médecins Sans Frontières who happen to come into Uganda is literally ridiculous. Like, that is both not the meaning of the words, but also is so stupid, I don't even know what to say about it. So if honestly that's the argument they want to make in the opposition, this debate is going to go absolutely nowhere. The debate is about whether or not you as a government have a right to restrict your citizens from leaving your country after the point at which they have gained an education through a system that you funded, something which incidentally already happens in other parts of the world. And here are some analogies, like for example how many governments, after funding your education, restrict your capacity to move. Like in Australia, where if you get an education that is a medical education, the government forces you to work in rural areas for 5 years to repay the cost of your education to the community. Like for example the Singaporean government, who pays for many people's educations to go abroad and then forces those people to work in service of the public to recuperate the cost that it invested in your education. The suggestion that this is like a random policy that would kidnap foreign nationals and keep them in your country is literally ridiculous. But let's question this. Let's presume for a second it's true that what we're talking about is literally forcing white people to stay in Africa and never letting them leave. Which of these things is more or less likely to scare you away from going to be a doctor in Africa? The threat that this moratorium might be extended to you, and somehow the United States government, the most powerful government in the world, couldn't, for example, get you back out of Uganda, or the threat, as described by them, of people with Ebola making you sick, or the example they gave you of literally white doctors during the Ebola crisis being stabbed and killed by patients who were afraid of those doctors. Which of those two things, in terms of a threat calculus, is more likely to disincentivize you? The suggestion that there is an overwhelming flood of Western doctors who are just clamoring to get into Africa to offer medical services, like, belies reality and also logic. That is not what's happening right now. The opposite is true. The transfer of people is from the developing world to the developed world. It's from those doctors who are leaders in the community in, like, let's say Uganda, or let's say India, getting more profitable jobs in the United States or in the United Kingdom. It is very, very unlikely that transfer happens in the alternate direction. And to the extent that it does, it happens through altruistic people who work for NGOs like Médecins Sans Frontières, who don't get a lot, and who understand that there are risks of offering medical services in the third world. We have a lot of respect for those people. We don't intend to force them to stay in Uganda because we think they want to be there. That's why they volunteer to go there in the first place. But we also told you, which gets no analysis, that those people are fundamentally incapable of offering equivalent services to local people as local doctors. They literally ignore this argument when their solution to this problem is more white people in this country. That's precisely the problem that exists right now, because there's insufficient local medical providers. You're forced to rely upon foreign doctors from Médecins Sans Frontières or any other NGO who fundamentally lack buy-in, which means people in that country will not show up to the doctor because they do not trust the person providing those services. It means that doctor will take significantly longer to actually come to an appropriate diagnosis because they don't understand the lay of the land, they don't understand the lifestyles of the patients, they don't understand the particularities of the diseases that exist within that particular geographic or like particular climate. So the actual outcome of their policy is to give these people even more standard medical care than our policy, which is to ensure that the people who are offering them services are people who understand them and people who they are likely to show up to in the first place. So if this was the outcome of our policy, which was that locals would provide these services as distinct from Westerners, we would be very, very happy with that outcome. Go ahead.
But then again, you're only improving the culture aspect and not extending their medical capacity, right? So how would they actually know when they don't really understand?
You ought to listen. You're improving their medical capacity because over time, the more doctors that are educated, the bigger the community of doctors becomes, the better the quality of medical services become. That's precisely what our argument was at the beginning of Bayrad's speech when he said the people who are likely to emigrate from the developing world are not likely to be random GPs in rural Kampala, but are likely to be doctors who are professionals and who are the top of the industry in that developing country, who have some notoriety, who would have some demand in the West. Because here's a hot tip: Australia doesn't just offer out visas to any random doctor from any third world country, because generally the education standards are not equivalent to the ones that are offered in Australia or in the United States, which means it's very hard for you to get a visa. So the people who actually emigrate are the people who we most need to stay. They're the people who are likely to be the dean of the medical school that the government sets up. They're the people who are likely to be consulted by the government when you're creating public health policy that actually defines how you educate people and what the medical community in general looks like in your country. So the suggestion that these people don't form an important part of this development was ridiculous. Then let's deal with their analysis of the problem, which Mark's very confused about. He says, oh, well, if development is so significant already, then who gives a stuff where they go? If they've invested so much, this policy is unnecessary. There's a difference between, for the past 15 years, a government investing very heavily in creating medical schools and creating public infrastructure and already having sufficient number of doctors. Spending money does not automatically equate to human capital, e.g. people who can provide medical services. So the fact that governments have invested money in education does not mean the problem is solved. It means that over time we will develop medical services. We will never do that if you take away the best people from that country and put them in the West, which is precisely the outcome of your policy. But let's be clear about why paying them to return is an insufficient alternative in this debate. First of all, it belies their characterization, which is that these people are altruistic, which incidentally they concede they're not by saying that they have personal and self-interested reasons for wanting to leave the country and go to the West. We think there's a combination of those two things. We think in general the medical profession, we can hold people who are doctors to a higher standard of altruism because they ought to sign up for that, and even if they do, for example, have personal interests in moving to the West, we think that's insufficient. But if it's true that money is the key driver, then we as the Ugandan government, will never be able to pay these people enough to warrant them coming back to Uganda, because if you're a medical professional that's actually sought after in the United States, you're likely to be able to out-earn whatever the Ugandan government can pay in incentives. So the outcome of their counter-proposal is that these people are incredibly unlikely to return, which means that these countries and their medical fields are stunted into the long term. This isn't just a question of one doctor providing one set of services. This is a question of the leaders of the medical profession in the developing world going away and being replaced at best by white doctors who cannot provide the same services we're very proud to propose. By the end of Gemma's speech, we know that Gemma loves Australia. But what is the context of this debate? The context of this debate is a less developed country, which they've already conceded. There is less medical infrastructure, and there are no existing programs, the ones that she wanted to talk about. And if you want to talk about those programs and how they benefit the people within those countries, we think then you don't need a moratorium. We don't think you need to mock us on how we don't understand the definition. Maybe we don't even need it at all. Firstly, let's want to talk about our what we've talked about and how they've completely misunderstood us to make us look like jackasses, right? See, we've already told you what Mark has said, right? We tell you that when doctors, the point that we were trying to make is that when these doctors need to emigrate there and ingratiate themselves into these cultures, right? These are the people that we talk about that you don't incentivize to stay, to gain citizenship, right? The problem with xenophobia that they talked about exists simply because you create a culture that rejects them, right? We tell you that under our model, we sell this better, right? Because we tell you because of the lack of understanding because the lack of understanding that occurs, right? We think that these continual of these problems in society exist simply because of their model. We think that when these sort of doctors are more incentivized to immigrate there, it helps the overall development of medical infrastructure. Because the odd thing that came from her speech was that she told you that simply because we stay in those particular countries, suddenly our healthcare system and doctors would suddenly improve their quality. We tell you that's not true. Mark has extensively told you about the importance of exposing ourselves to more developed countries and how their healthcare system better. When we expose ourselves to that, our doctors become naturally better. This is where the incentives that we talk about come into place. When we incentivize them to stay, instead of forcing them to incentivizing them to go out there and come back and stay and do better for the healthcare system that you wanted to talk about, right? We tell you that under their system, the local doctors would forever stay in those circumstances and never necessarily improve because there are no better techniques. And these cultural doctors that they wanted to propagate so much, these are the very same exact people who stick to cultural solutions, right? Such as they don't even believe in abortion, sit down, right? Because you can't just pick a characterization that fits you, especially when we're talking about various definitions of third world countries, of various definitions of less developed countries. You just can't pick one country and use that characterization just because you're Gemma, Berat, Mustafa, right? Sit down. See, we tell you also, no, sit down. We told you also, like, when you harm altruism, we tell you that local doctors, right, will work less effectively. This is something Gemma's completely ignored. Mark has extensively told you, especially when they talk about this one characterization where doctors will be less altruistic. We tell you we serve them better if they were altruistic or not. We told you if you believe the characterization that, no, sit down, that doctors are self-sacrificing, then you don't need this international this moratorium, right? Because they would be incentivized to come back and help the people itself. We tell you that if they are not as self-sacrificing as you want to believe, then these incentives will work better, because we tell you under your moratorium, these people would be resentful and will work less effectively than they would under our model. Before I go on, yes, Behra.
Can you tell us why a doctor who is already well off in the developing nation, and despite that has already left the country and has been exposed to a more convenient medical practice, would ever come back to your country?
But I just answered that. If you believe that they are self-sacrificing, then these are the people who would come back and develop your industry. If you don't believe they are, then we provide incentives for them to come back. That is a method that has worked for Malaysia even, right? And then we are talking about less developed countries, right? If you don't believe that, then you need to prove to me how those incentives don't work. Sit down. We tell you also, then they also told you about the benefits that their local industry would better. But how does education work? And if you want to talk about improving healthcare overall, we tell you that we do it better, right? Because we tell you that these, we incentivize these people to return, and these people can come back and help develop the healthcare system overall. We tell you that we would remove those cultural local solutions that harm these people in the long run, instead of believing the long-term benefits that Berat wanted to talk about. Now, going on to rebutting whatever Berat said. Actually, no, I've tackled that. There's xenophobia and how you lose incentives to become, you lose incentives to become a proper expert, especially when there is a comparative of better infrastructure outside, and how we can use that to develop ours better. No, sit down. One argument for you today, right? We're going to compare the two characters that existed and talk about how we have better outcomes and consequences under our side. Let's talk about the consequence, because we understand in third world countries there's various stages of development, right? But let's assume firstly that there is a lack of infrastructure, right? We tell you there is a need to incentivize these people to stay and improve those infrastructure. Because let's talk about how their healthcare will improve, right? When you have this sort of moratorium, we tell you that the sort of like, because of the limitation, right? Because you're inside the box, the sort of innovations that could have come when you adopt Western policies or whatever, Western innovations in healthcare, those things would not exist because you don't allow your doctors to go out there, gain that knowledge, and come back. But we tell you that also when there's the whole misunderstanding of mass characterization, right? We tell you when you disincentivize for anyone from those first worlds to come into your country, integrate themselves into your culture, and get, I don't know, like a permanent citizenship, right? You prevent those people from coming there in the first place because they don't because of the things that I've already talked about. No, sit down. But let's talk about the characterization where you have medical infrastructure, right? We tell you that those doctors who stay, they're unable to educate anyone around them. What that means is that the quality of work that you promote overall reduces. And the quality that you can educate future doctors as well reduces, simply because of the lack of knowledge transfer between the developed nation and a less developed nation, right? So we might tell you that the sort of characterization of resentful people that we talked to you about, right? Also we tell you about who incentivize, right? It's people who have experience, go out there, come back. We tell you that these are the sort of circumstances that benefit healthcare in the long run. So what are three I told you about? We told you about the sort of expansion of knowledge, right? And we told you about how we deter doctors moving out better with our incentives. We told you about how the perception of helping when we don't actually do it exists in their case, right? When international community sees it as a solution to the less developed nations, when it doesn't really occur. For all those reasons, we are very proud to oppose.
Mr. Speaker, our characterization of doctors was never that they are by nature altruistic, but rather that their profession allows us to hold them to a higher standard of altruism, because that is what medicine is about. It is about sacrificing your personal gains, i.e. a higher salary in the United States of America, for serving your community in Uganda and Kenya, where there is a shortage of doctors when compared to the amount of crisis that occurs within those nations. Their biggest response to this was let white doctors deal with it because white doctors want an Ugandan citizenship. Not sure why a white doctor wants an Ugandan citizenship. But we told you that the biggest problem with this is the fact that these doctors are unable to relate to people on the ground. We never told you that the doctors who exist on the ground are witch doctors. We told you that these doctors better understand the cultural sensitivities that occur on the ground. But more importantly, from a medical point of view, better understand problems or diseases that are specific to that particular geographical region. So, let's understand a couple of things before I move on into sort of the depth of analyzing their case. Their biggest issue was that the doctors on the ground are ill-equipped. The fact that these doctors are uneducated, will never be exposed to any information, because the only way you can get to do so is by going to the United States and working there, getting a better salary, and probably not wanting to come back, therefore we have to pay you a lot more. Two issues we had to that, two responses. First, the fact that the government has already spent on you should be sufficient incentive for you to stay, or should be sufficient reason for us to have a reason to keep you to stay. Therefore, financial incentives just serve to burden the government a lot more than it already has spent, and therefore disallows the government from actually spending on equipping and educating other doctors within that country who will then eventually become specialists. But the second issue with that is the fact that exposure to information about medicine and diseases isn't contingent on your immigration to other nations. And that's where the engagement comes in. What we've got to understand is that most of the time, doctors who are at the top or the front of their careers in countries like Uganda and Kenya, who are deans of the medical school, etc., are more often than not foreign educated on the basis of sponsorships given by the government and have to return to their countries to serve their nation. So they do have the sort of education that you talk about. But even if they're ill-equipped, why is it that Uganda can't hire doctors from the United States of America to come and educate these people locally and therefore prevent them from having access to jobs overseas? But more importantly, why can't doctors, white doctors in the Telkobat, who come and voluntarily practice in these nations, not communicate with these doctors and talk to them about, say, Ebola and the advances in medicine when it comes to Ebola? But let's assume nobody's going to go anywhere. Uganda doesn't have the money. White doctors are not going to come. We think it's still possible for you to find out this information by reading medical journals, because that's how you learn when it comes to medicine. The fact that this information is existed in a wide range of books, journals, etc., etc. So therefore, it is actually possible for your ill-equipped doctors, assuming they're ill-equipped, to be able to become better educated. But belying that, we've got to understand that the doctors we talk about are actually the best in their career, because we told you that the people who are more likely to emigrate, not attend conferences, not travel for education or meetings, and not travel for public policy discussions with the government of the United States of America, emigrate, i.e. up and leave their country for a visa in another country that allows them to get a job or to get employed in another country. These doctors are more often than not at the frontier of their careers. They're not the doctors who are your local random GP who doesn't know much. So we're not talking about the ill-equipped doctors. We're talking about doctors who are experts in their field and actually contribute to the nation insofar as medical policy is concerned, medical infrastructure development is concerned, but more importantly, education in these countries. So these are the people who actually resolve the problem of ill-equipment of these nations. Before moving on, yes?
Western doctors as much as say they do, why would they trust a doctor who's been trained, who's been educated by Western knowledge anyway?
Perhaps if we spoke the same language and we lived in the same community for the longest time and I grew up with you and you're my neighbor, I have a greater likelihood to actually have some degree of faith in that you understand my culture. Perhaps when you as a male doctor are faced by a female patient, you say, excuse me, let me call my female colleague to come and see you because you need to get undressed. You are able to understand and appreciate that this person is one of you. There is a special relationship that is built by simple virtue of being from the same background as another individual. That by default gives you a high likelihood of trust. The other issue they had was that these doctors never consented to being in environments where Ebola happens. Well, believe it or not, When doctors study medicine, they understand that at any particular point in time in their practice, they may fall ill as a result of their patients. From the common cold, when you walk into a doctor's office and you might infect them through a sneeze, to the probability of a doctor conducting surgery on a patient who doesn't know they have AIDS and therefore unintentionally gets pricked by a needle that involves them getting HIV, doctors are very well aware of this risk. Whether in the United States of America or in Kenya, you explicitly consent to that risk when you become a doctor. That is exactly why a specific part of medicine and medical education is targeted at hazard management and the ability of doctors to manage the risks that they get exposed to. We assume that at the beginning of that class, you'll be told that there are biological risks that you expose yourself to. Therefore, you need to know how to reduce these risks. So not only are these doctors aware of these risks, they're also equipped to manage these risks. But even if they're not, it is part of the medical profession to expose yourself to that risk. That's the standard that we uphold these individuals to. Back to their solution. Their solution to this problem was white doctors. We tell you that's problematic, but also their solution of white doctors and how they say our policy doesn't facilitate white doctors moving in. So let's assume white doctors is a good solution. Our moratorium does not in any way prevent these white doctors from moving to these countries, volunteering as they wish, and moving back to the United States of America, because kidnapping is illegal by domestic law and international law. So what does this debate ultimately boil down to? The biggest question in this debate is, how do we ensure a sustainable development of medical industries in developing nations? Is it by allowing the most important specialists in these nations to leave, get jobs overseas, where they're probably going to be paid higher, and you'll have to pay them so much more in order to convince them to return to shitty Kenya, but most likely not be able to do so? Or do we do that by allowing these individuals to leave? We tell these individuals not only provide immediate assistance in cases like Ebola, where having an immediate response team is crucial, one that is educated until other assistance comes in, but these are the individuals who propagate education within these nations. They told us doctors in Kenya and Uganda are ill-equipped. We tell you there are doctors in these countries who are not ill-equipped, and those are the people who are most likely to leave. They've got to respond to that. Why are they okay with the most important people in these nations who are best equipped to treat diseases there to leave these nations, and the government have to spend so much money but ultimately not be able to return them back to their nations?
See, the problem with the government side is that they think that suddenly, if we do not allow these people to go out, we will have a self-growing community. And then when we provide alternatives of how these communities grow with foreign action, they say, no, foreign action is too expensive, we cannot opt for it. Then I wonder, is their culture the cap of development, right? Because if you say foreign doctors and hiring white people is expensive, that means you're culturally capped in your doctor's experience and you cannot expand anymore. They think just by staying in your own country, people will find out a cure for a certain epidemic or disease. See, if I don't have research facilities in my own country and my government cannot make them for me, how can I even find out a disease, cure for that epidemic that's happening in my country? I would rather die there as a doctor as well, right? There will be no results in the end, right? But then again, we have to beat them in their own game if we want to show you how benefits and harm works on both of the sides. All right, first question is that, why do doctors immigrate to start with? This was a real, like, okay, like forget altruism. Everyone is greedy in this world. And yeah, when Bangladeshi doctors go to America, yeah, they don't come back. But you cannot even detect if they come back or not because they immigrated to a different citizenship. But then I tell you what's the benefit when they immigrate from developed country and go to from developing country and go to the developed country. You improve the medical system in the developed country. But then I'll show you what the trickle-down effect is if you improve the medical system in developed countries. See, when people from Bangladesh or India goes to America, they also carry those cultural benefits that they wanted to talk about, and it assists them in aiding development in those developed countries to also consider those kind of values in their education of medical to start with, right? So what happens is that you're sharing info that goes to these developed countries, and what benefit for these developing countries? I'll tell you what the benefits are. These NGOs and global bodies that they talk about that come to help develop countries, these are the countries that are going to get this education to begin with, right? And they're going to come back and use those education base to help those countries and not feel that there's a lack of communication that Berat wanted to implement, and not have a lack of cultural barrier to begin with. They're well educated about it. That is why when Germa talks about only white people coming from America to these developing countries, that is false, because not only, this is not limited to white people only coming, right? Because people who already immigrated to those countries can also come back and help out, because they are also considered helpers of those medical bodies that have been established in those developed countries. So you cannot assume that they do not develop and they do not come back to begin with, right? That is a false assumption to make, and we believe they will come back if they truly believe that their capabilities of duties are there, and they would go because they are doctors in the end. Like, no. And then moving on, I'll take it later. Moving on the whole idea of how that there can be sponsorship of education, that they can already get foreign experience. See, sponsored education is still not enough when it comes down to covering down the whole research infrastructure that you'll still lack when you are in your own country, right? You will feel the lack of infrastructure that you cannot provide for your country. What is the exclusive benefit that these people get when they immigrate and join those bodies is that they get to use those research facilities, right? And they can actually use their infrastructure to help these developing nations in the end, right? That's how it works. How do you make NGOs stronger, and how are NGOs formed, right? These are formed by developed countries to begin with. You empower these NGOs to have people experience from those developing countries entering these kind of NGOs and then using their own resource to help their country. See, this is how we easily get away by solving problems like in scenarios of Ebola, where we do not want cultural shock by sending white people in there. That's how we solve these kind of problems, right? We educate an African man in a developed country and then send him there through the same process, but now he can better interpret and better communicate with these people and still use all those information and resources to begin with. So we already solve a problem, an epidemic or whatever disease that might outbreak better under our side. But then again, then comes the question of education, right? Are these experts the main successor of providing better courses and education in this country? I'll talk to you how we benefited better under our end, but before that, yes.
Most third world nations suffer from a lack of medical expertise or medical services to treat things like the common cold, diarrhea, and other diseases that have established cures, but you need the doctors to cure them. We don't have cancer. That's a developing field of education. So respond to that. You need a doctor who can treat the common cold with information that exists in medical journals and doesn't need a research center. So why is a research center necessary?
Wait. Did you just hear that, POI? Now you're going to limit these doctors to stay in their country and not even know about diarrhea, and you expect these people to expand their knowledge and suddenly help everyone else. How are you going to expand their knowledge if they're capped to such puny knowledge to begin with, right? We're expanding those. Going to a developed country doesn't necessarily mean you're going to study about cancer, right? You can study about whatever you want to study, right? That's the benefit of going to those developed countries, and you will choose your majors and what you want to study in the doctor field. It's not like going to a developed country means studying cancer by default. So that is an assumption that you make. But then the whole idea about education, who improves education on these developing countries to begin with? See, we already give you an alternative that we can provide incentives for these people to come back. But even if we throw incentive away, right? Think of how this would work. Education in these countries are not, if we imagine their scenario, it's going to be capped, right? It's going to be capped because these doctors will be only in line with whatever they have and whatever their country has to provide, right? They will not expand their knowledge beyond that. So basically, what you're doing is creating a generation of doctors which will never develop in the end, and always consider white foreign doctors as a third party that we should not follow, because they clearly said that these people have cultural communication blockades, right? So you're creating a generation that will never improve. You're creating a generational lock for these doctors to never improve because they lack in infrastructure and they cannot do anything about it. So guess what? All these diseases that will spread out and these doctors cannot solve it will remain unsolved in the end, because these doctors are not developed or do not have that capacity to help solve these diseases, and they cannot provide this kind of education, because now you're limiting education only to the cap of those expertise. We believe an education system for doctors should not be capped by your own country state, but rather than your education of doctors should be capped on the general basis of any country, right? We believe just because you stay in Malaysia or just because you stay in underdeveloped country doesn't necessarily mean you have to cap your knowledge only to that country's country specific, right? We believe you can equally have education of United States standards, right? We believe how can we achieve that is by sending our own doctors, making sure they bring all those knowledge from there and incentivizing them to come back so we avoid those blockades of communication and use them and gain the knowledge that we wanted to gain in a better manner and better structure, Honorable Speaker, and thus provide better courses in our education and expand education. We believe just because we are developing doesn't mean we should not think like a developed country. We can dream, Honorable Speaker, and we will dream, and we will have better education in medical. With this, we are proud to oppose.
The opposition wins. Now I'd like to call upon opposition reply speaker. Yeah.
Okay. Alright. I actually blame a lot of the initial confusion on Berat's characterization in this debate, right? Because when he provided a context that we had third world countries that were sufficiently rich to develop medical institutions but somehow had a shortage of doctors, we thought that was both incredibly unrealistic and also incredibly difficult to debate in. Because the moment we challenged them on the premise that they did not have sufficient medical infrastructure and that their locals needed to travel abroad to gain knowledge in order to develop local medical community, they told us that no, wait, they have the infrastructure. But when we challenged them on that very same thing, they told us no, but we didn't have the doctors either. We thought that was incredibly difficult and made it an unfair burden for us to take up both instances at the very same time, right? So we thought that it was unfair to characterize a third world country because both medical advanced but had no doctors at the same time. So let's talk about what happened in this debate, right? What are the problems faced by third world countries and which side solves it better? And secondly, how to improve local medical communities and which side would better facilitate that? So, right, we told you that in situations, firstly, West Africa has no medical institutions to handle specializations for furthering the education of their locals, right? So we told you that locals needed to leave so they can return from knowledge from the first world, whatever the hell that is. And we told you that self-growing communities where locals just traded knowledge among each other was insufficient, and that you never developed the kind of medical community that they wanted to talk about that would eventually blossom and grow to become a community that could handle outbreaks like Ebola and other outbreaks they wanted to talk about, right? Secondly, right, pandemics. We told you that because they are unable to do so, that locals are unable to handle virulent outbreaks because of insufficient training, and they have prevented them from leaving in the first place and gaining that valuable information that could subsequently be used to help their situation. So we tell you that eventually when pandemics break out, you actually need first world doctors to emigrate for extended periods. But then their problem came in, right? Towards the second speech, right? Xenophobia. Although, yeah, Berat actually talked about it as well. Xenophobia. But we tell you that they're only exacerbated when you empower the rhetoric that only locals can treat these people. When they're only locals that speak the same language, have the same culture, were qualified to treat these people. We thought that xenophobia was exacerbated underside when they only contained local doctors into treating these people. And we tell you that when local doctors were congregated and prevented from leaving, they created the kind of circumstances that disincentivized more doctors from coming in because it gave the impression that the problem was already being solved. And he talked about locals leaving. We told you that we recognize that problem exists, and that's why we thought that financial incentives were better than simply preventing them from emigrating in the first place. Because we told you that if you could build all the infrastructure that they want to talk about in the first place, you could also provide incentives. But secondly, we think that you would come back to your country because we think doctors don't really like leaving their people to die. We think that unless you're Mustafa, who has completely abandoned Egypt altogether, you're more like Berat, right? That's a more reasonable person we think in this debate, right? That a person that will go back to Iran and help develop their nuclear program sometime in the future. We think locals do go back, and in fact we encourage this, but we don't prevent Berat from leaving Iran in the first place. We thought that was unrealistic. But how do you improve medical conditions? Because I told you that a self-contained medical biosphere that would be unlikely to develop by simply trading information among locals. That if medical journals was sufficient to learn about medicine like Mustafa wanted to propagate, then IMU students, you wasted a hell of a lot of money on your education because you should be subscribing to magazines because that would be sufficient to get the kind of knowledge that he talked about, right? So sometimes we tell you that emigration, the extended periods of internship in first world countries creates work experience that is vital to these medical communities to develop. That is superior that doctors go out and then return with the information that we're able to get. And if they did not want to come back, if for some reason they were this arrogant bastard that thought that living in first world countries was better, helping the people back at home, then we provide some kind of incentives to ensure that more would. And even if those people did not want those financial incentives or were simply unwilling to come back, we ultimately told you that we don't even want those people to come back at all, because they probably be unable to be of any use to communities if they did anyway. That is the conclusion of the case. We were very proud to oppose.
Mr. Speaker, if I expected any team to flagrantly not listen to Bayrad's speech or claim they couldn't understand it, it wasn't APU A. Let me clarify a couple of things about what Bayrad said in pretty plain English in his speech. First, that developing nations, as the word would suggest, are developing. Therefore, they have some investment in medical infrastructure and some investment in training individuals and providing them an education, but insufficient numbers of those people and insufficient capital to create more of those people by having to bring in foreign doctors or spend a huge amount of money to enforce returning upon those people. Secondly, he said doctors, when they sign up to be doctors, can be held to a professional standard of giving back to the community and putting their own interests second. Not that they were altruistic all of the time, and not that, in fact, that conceded our case. So now we've got those two things out of the way, which I think are pretty clear to begin with. Let's ask one question at the end of this debate. How do we ensure good medical services for people who live in the third world, e.g. the debate? The long-term solution to this crisis was obvious, which is we needed educated people who lived in the developing world, who were from the developing world, who could provide the kind of trust and buy-in that we spoke about, who could provide these services. So the question was twofold. First of all, what services did they need? Secondly, how would we get the information to give them? The overwhelming majority of analysis of the opposition in this debate is like, how would the third world treat really complicated breakouts which required huge levels of innovation? When in actual fact, what the overwhelming majority of needs were in the developing world was primary healthcare, things like maternal healthcare to ensure babies didn't die during childbirth, things like fighting the common cold or diarrhea, which kills hundreds of thousands of people every year in Africa. These were not things that required you to have years and years of exposure in high-level research institutions in the United States or Germany. They were things that required you to have a basic medical education and have good public policy that defended your capacity to actually treat those diseases. So when we heard from the final speaker, we can all dream of being the developed world, we can't. We can't dream of being a country that only has to worry about the most effective cancer treatment, because we are a country that has to worry about any treatment at all for basic diseases which are rife throughout our country, no engagement on the actual context of this debate. But secondly, how did we get it? And at the end of this debate, I'm left honestly asking myself how any innovation ever occurred before globalization. Because if you were to believe the opposition, the only way that anyone can learn anything is to physically move countries and physically be in an educational institution in the developed world. We said that there were a number of alternatives that already existed and were already effective. Like, for example, reading medical journals or reports from research institutions in the West which do the research themselves, like, for example, having professional communication with doctors, like, for example, attending professional conferences where you talk about what is the world's gold standard best practice for administering things like chemotherapy. It was unclear to me why those things, plus the invention of the internet, was insufficient to communicate innovations across geographical locations. So at the end of this debate, their only major claim of the harm of this debate was that if you were already in Africa, your education system and the things you knew could never get any better. That was obviously false. So, given we could do that, would we prefer these people to stay and provide services in the meantime as they're educated and gain buy-in and gain faith, or would we prefer them to leave and go to the West? Because for you to believe that there was a benefit in these people moving countries, you also had to accept that these people would return. And this was the major part where their case fell down. They said these people who aren't altruistic, who move because of money, can be enticed back with money. And the question we're left with at the end of this debate, could we offer them enough money that would outweigh the financial benefit of them living in the West? And even if we could, at what cost? Because that cost would be to building a new hospital or educating more people or actually buying needles so that you can administer the very treatments that we talked about in this debate. We were the team that actually protected people who needed healthcare. We were proud to propose.
Thank you guys for the debate. We have crossed the floor. Shake hands.
Oh my God. He's gonna draw in my face this time.
You guys, attention.